Hi there, I'm Brian Thurber. I'm a neuroradiologist with an interest in medical education. This video is dedicated to cross-sectional neurovascular imaging. We're starting here with an axial CTA through the head and neck, and I'll first point out the great vessels. Here we have the innominate or brachiocephalic artery. It is usually the first branch off the aortic arch. Next we have, right here, the left common carotid artery, and behind it we have the left subclavian artery. As we work our way superiorly, we'll see our innominate artery divide into the right subclavian and right common carotid arteries. The first branches off the subclavian arteries are the vertebral arteries. A little further up, we'll see these coming off their posterior and superior aspects here and here. In this particular patient, these vertebral arteries are about equal in caliber, though differences in size are actually quite common. The vertebral arteries are divided into 4 segments. This first segment is the V1 or preforaminal segment. It will course from the ostium of the subclavian artery up until the transverse foramina of the cervical vertebrae. It will course posteriorly and medially as it goes up and go right between the anterior scalene muscle seen here and the longus colli muscle medial to it. As we work our way up, we'll see it go by the C7 vertebra right here. It does not enter the C7 transverse foramen in very many cases. 7.5% of the cases it will in fact enter at this level. More often, as is the case for this patient, it will enter at the C6 level right here. This is where the V2 or foraminal segment begins. We can follow this up here through the C5, C4, C3, and then C2 levels. At C2, it will exit out laterally and become the V3 or Atlantic segment. This segment is also known as the extradural segment. It goes out here laterally and then works its way up to get into the C1 transverse foramen right here. And then it will go out laterally and curl behind the lateral mass of C1 right here. Sometimes you can have a bony bridge when there's calcification of the posterior atlanto-occipital membrane here, and this is called an arcuate foramen. As it continues medially here, it will enter the dura and become the V4 or intradural segment. This is sometimes also called the intracranial segment. The V4 segment continues up until it meets the contralateral vertebral artery to become the basilar artery. On our coronal CTA images, we again see our brachiocephalic or innominate artery here coming off as the first branch from the aortic arch. As we work our way posteriorly, we'll see it again divide into the right subclavian and right common carotid arteries. Further posteriorly now, we'll see our left common carotid artery and then our left subclavian artery. The first branch off the left subclavian here again is our vertebral artery. In about 5% of cases, the left vertebral artery instead arises from the aortic arch. When it does this, it's usually between the left common carotid and left subclavian vessels. It has also been reported in rare occasions that the right vertebral artery may come off the aortic arch. We can see our V1 or preforaminal segment of the left vertebral artery here, and as we go a little further posteriorly here, we'll see it enter the C6 transverse foramen. If I scroll anteriorly again, we'll watch it go through the C5, C4, C3, and finally C2 transverse foramina. At the C2 level, it assumes an inverted L configuration here. This is where it exits and becomes the V3 Atlantic or extradural segment. A little further posteriorly, we see it coming out laterally, and then as I scroll anteriorly again, we can watch it go up through the C1 transverse foramen, which is right here. Next, we're going to scroll posteriorly again to watch it curl around the lateral mass of C1 at this point. This is where you potentially have an arcuate foramen, where there is calcification of the posterior atlanto-occipital membrane. Now going anteriorly again, we're going to see it enter the dura to become the V4 intradural or intracranial segment, until at this point it merges with the right vertebral artery and becomes the basilar artery. Returning to our axial CTA images, I'll again point out the right and left common carotid arteries. We'll now follow them as they ascend through the neck. Scrolling superiorly here, we'll pass by the thyroid gland, pass by the cricoid cartilage, and pass by the thyroid cartilage. It is generally at the upper margin of the thyroid cartilage, or at the C3 to C5 cervical levels, that the common carotid arteries will divide. So going a little further up here, we're going to see our external carotid arteries come off anteriorly. The external carotid arteries will have multiple branches, the first of which will come off anteriorly and will be the superior thyroid arteries. Going down just a little bit, we can see our right superior thyroid artery coming off right here, and we can follow it inferiorly. So here's our right superior thyroid artery working its way back down the neck to the level of the thyroid gland below, right here. Scrolling back up, we'll go to the proximal portion of our external carotid artery again, and I'll point out the next branch coming off right here. It's a very small, slender branch that is going to go and ascend up toward the pharynx. This is the ascending pharyngeal artery. The next branch, we'll see if I go a little further up, will be the lingual and then facial arteries. In this patient, there's a common trunk for these two vessels that's seen right here. If I scroll up just a little bit here, we're going to see the lingual artery coming right here, and then I'm going to scroll back down to follow it this way, right here, and then we'll see it connect up to the more anterior portion here. If I scroll superiorly once more, we're going to watch it go to the tongue base and further anteriorly right here. I mentioned the facial artery has a common trunk in this patient, so we'll see that if I scroll back up superiorly a little bit. Right here is the right facial artery. It tends to have a very tortuous course and go out around laterally to supply the soft tissues of the face. We'll next see the occipital artery come off the posterior surface of the external carotid artery here. As we scroll up, we'll watch it come out anterior to the internal jugular vein right here, and then work its way out lateral to it. Here's our internal jugular vein, and here is the occipital artery, which is continuing posterolaterally, and will go behind the mastoid process of the temporal bone here, and then come out this way to supply the occiput. Scrolling back inferiorly, I'll next point out the posterior auricular artery. The posterior auricular artery is seen right here. It will come out to supply the soft tissues behind the ear, and will also go to the auricle itself. Lastly, I'll point out the terminal branches of the external carotid artery. Here's the most terminal aspect of the external carotid artery, and it is at this point, right up here, that it is branching into the maxillary, also sometimes called internal maxillary artery, and out here, the superficial temporal arteries. We can follow the superficial temporal artery as we go up and see it divide in the infratemporal fossa to multiple terminal branches. On our coronal images, we again see the external carotid artery branching off anteriorly. As I scroll forward, we'll see it branch here, anterior to the internal carotid artery, and give off its first branch, which will be the superior thyroid artery seen right here. It will go down to the thyroid gland. Scrolling posteriorly one slice, I'll point out the ascending pharyngeal artery seen right here. Scrolling back anteriorly now, I'll show the lingual and facial arteries as they come off. From this point right here, more medially, we'll have the lingual artery, and a little more laterally, and following a tortuous course, we'll have the facial artery. So let's follow these anteriorly. Here we have the lingual artery coming down towards the tongue, and the facial artery coming out this way to supply the soft tissues of the face. Scrolling back posteriorly now, next I'm going to point out the occipital artery. The occipital artery is going to come off at this point here, and then as I scroll posteriorly, we'll see it work its way up, posterior to the mastoid process of the temporal bone here. So here it is going out to the occiput. Next we'll scroll anteriorly to take a look at the posterior auricular artery. Scrolling further anteriorly here, we're going to see it come off right here from this end portion of the external carotid artery, and then work its way back posteriorly like so. Here is our posterior auricular artery here, going out posterior to the auricle, and then supplying these soft tissues in this region, including the auricle itself. Scrolling back anteriorly, I'll now point out the terminal branches of our external carotid artery, which will be seen branching off from this point here. Here we'll have the superficial temporal artery going out laterally, and the internal maxillary, or simply maxillary artery, working its way medially. So I'll scroll a little further anteriorly here to watch them bifurcate here and here. Here we see the superficial temporal artery, and here we have our maxillary artery. Self-opams is a simple mnemonic we can use to remember the external carotid artery branches: superior thyroid, ascending pharyngeal, lingual facial, occipital, posterior auricular, maxillary, and superficial temporal. We'll now turn our attention to the internal carotid arteries. Here on our axial CTA we have our right and left internal carotid arteries located posterolateral relative to the external carotid arteries which we just discussed. The first segment of our internal carotid artery is the C1 or cervical segment, and this segment will extend from this point at the common carotid artery bifurcation point up to the skull base at the carotid canal. This first segment is slightly dilated in its first 1 to 2 centimeters, and this is attributable to the presence of the carotid bulbs. As we continue superiorly, we'll notice that this internal carotid artery cervical segment has no branches, and that it goes from a posterolateral location relative to the external carotid artery to a more medial location further up. Here's our right external carotid artery, and here's our right internal carotid artery cervical segment now medial to it. Sometimes the right and left internal carotid arteries can actually meet at midline, such as here in the retropharyngeal space, or alternatively, this can occur in the pituitary fossa or in the sphenoid sinus. When this occurs, it is called kissing carotids. Recognizing and reporting kissing carotids is important, as they may affect presurgical planning for tonsillectomy or transsphenoidal surgery. We'll now continue to follow our C1 cervical segments superiorly until they enter the skull base up here at the level of the carotid canals, seen here on the right or here on the left. At this point, they'll transition into the C2 or petrous segments. This is the first intracranial segment and will course anteromedially, like so. There are small branches off the petrous segment. Sometimes a caroticotympanic segment can be seen coming off proximally. More rarely, in cases where the maxillary artery has small vidian and mandibular branches, you can also then see mandibular and vidian branches coming off the petrous C2 segment. But it is common for none of these vessels to be visible angiographically. One case in which you have a clearly defined caroticotympanic artery will be seen in cases of a persistent stapedial artery. In these cases, a branch is seen coming off proximally and heading over to the middle ear cavity. Let me show you an example of this on a temporal bone CT. Here on our thin-cut axial CT images, we see the petrous C2 segment of the internal carotid artery here. Coming off of it posteriorly, we'll see our caroticotympanic branch right here. The reason it is prominent in this particular patient is because it is giving rise to a persistent stapedial artery. As we scroll superiorly, we'll see this come out laterally and get lateral to the cochlear promontory right here. Sometimes, this canal may become confluent with the facial nerve canal, resulting in widening of the facial nerve canal, or it may run parallel to it, as is seen in this case. Sometimes, the persistent stapedial artery instead arises from an aberrant internal carotid artery. An aberrant internal carotid artery occurs when the distal cervical segment down here fails to form just before the carotid canal, and as a result, a collateral pathway needs to develop. This occurs between the external carotid artery's ascending pharyngeal branch, and specifically the inferior tympanic branch off of the ascending pharyngeal branch, which will then go up to merge with the caroticotympanic artery in the area we just discussed. The other thing to look for in these cases of persistent stapedial artery will be absence of the foramen spinosum, which usually will indicate that the middle meningeal artery no longer has to traverse the skull base, as it is coming directly off the persistent stapedial artery. We'll continue to follow the course of our internal carotid artery beyond the C2 petrous segment to the posterior margin of the foramen lacerum seen here. This is where our C3 or lacerum segment will begin. It will go over the foramen lacerum. Remember, the foramen lacerum itself is occluded with cartilage. After this short vertical segment, we next hit the cavernous or C4 segment, which will start by going superomedially up against the posterior clinoid process, seen right here, and will then head anteriorly before going vertically again to reach up to the anterior clinoid process up here. The C4 segment has meningiohypophyseal, inferolateral, and a few other small branches. We'll next encounter our C5 clinoid segment, which extends a short vertical distance here from the proximal up to the distal dural ring near the anterior clinoid process. It normally has no branches, though occasionally the C5 clinoid segment may give rise to the ophthalmic artery. Going further superiorly here, we'll next encounter our C6 or ophthalmic segment, beginning here, and we see it give rise to our ophthalmic artery coming out here and going towards the orbit. The C6 ophthalmic segment will then go back posterolaterally, like so, to this point here. We know this is the end of our C6 ophthalmic segment because it is at this point we see our posterior communicating artery coming back here. This is therefore the beginning of our C7 communicating segment, which further out will give rise to the anterior choroidal artery and then finally bifurcate up here into our anterior and middle cerebral arteries. We'll now briefly review our internal carotid artery segments here on our coronal CTA. Let's begin here with our C1 cervical segment and scroll anteriorly to watch it work its way up the neck. As I scroll anteriorly here, we see it going superiorly until it reaches the level of the carotid canal right here. At the carotid canal, it becomes the C2 petrous segment. I'll continue to scroll anteriorly here to watch the petrous segment go anteromedially towards the petrous apex, up to the posterior margin of the foramen lacerum. Here we have our C3 lacerum segment going over the foramen lacerum and then working its way vertically for a short segment before becoming the cavernous C4 segment, which goes up superomedially initially up against the posterior clinoid process. And then as I scroll further anteriorly, we'll see it go anteriorly in the cavernous sinus. The C4 segment will then become the C5 segment at this point right here at the proximal dural ring. Between the proximal and distal dural rings, we have the C5 clinoid segment going up against the anterior clinoid process. Next, we'll have our C6 or ophthalmic segment going from the distal dural ring and giving rise to the ophthalmic artery out to the posterior communicating artery. To see this, I'll scroll posteriorly again, and we'll see our ophthalmic segment here going back to this point right here. Scrolling posteriorly just a little more, we can see a very small and faint posterior communicating artery right here, and then it is at this point that we are in our C7 communicating segment. Now, we don't see the anterior carotid artery well in this patient, but we do know this is another important branch that just precedes the bifurcation point right here into the anterior and middle cerebral arteries. Here on our sagittal images, we again see the distal segments of our internal carotid artery extending up to the terminus here. From this point, if we scroll out laterally, we'll see the M1 segment of the middle cerebral artery. If instead we scroll toward midline, we'll see the A1 segment of the anterior cerebral artery. This will continue toward midline until it reaches the anterior communicating artery and breaks off into the A2 segments. Let's now review some maximum intensity projection images to review the distal segments of the anterior cerebral arteries, and then we'll move on to discuss the middle cerebral and then posterior cerebral arteries in further detail. Here on our patient's sagittal maximum intensity projection CTA images, we get a good view of the distal segments of the anterior cerebral arteries. We briefly discussed the A1 pre-communicating horizontal segments extending up to this point at the anterior communicating artery. Next, we have the post-communicating A2 segments, also known as the infracolossal segments. They extend from the anterior communicating artery to a point anterior to the genu of the corpus callosum. Alternatively, their endpoint can be marked by the origins of the colossal marginal arteries, which typically will run posteriorly and go superior to the corpus callosum just within the cingulate gyrus or posterior to it. Next, we have the A3 precolossal segment. This is a short segment running anterior to the genu of the corpus callosum. Once it begins turning posteriorly, it is called the A4 supracolossal segment. It is supracolossal because it is above the corpus callosum at this point. It is also a fairly short segment, which lasts until we're in the coronal plane of the coronal suture coming down. So posterior to this point, we're going to be in the A5 postcolossal segment. Let's now take a look at our patient's coronal maximum intensity projection images to review the segments of the middle cerebral arteries. On this slice, we see our internal carotid artery terminus right here, where it divides into the A1 segment of the anterior cerebral artery going medially, like so, and into the M1 segment of our middle cerebral artery going out laterally. The M1 segments are sometimes called the sphenoidal segments because they lie approximately 1 centimeter posterior to the sphenoidal ridge. If I scroll anteriorly, we'll see our sphenoidal ridges here on the right and here on the left. Going back posteriorly, the middle cerebral artery M1 segment will extend from the internal carotid artery terminus to the anterior aspect of the insula, or alternatively, its endpoint can be defined by its branching point. Usually, it bifurcates, including in this patient, into 2 main branches, though trifurcation and more complex branching patterns are also seen. The M2 segment will extend from this point here and then go posteriorly and superiorly up the sylvian fissure. So if I scroll posteriorly here, we're going to see it extend this way up to the point right here at the top of the sylvian fissure, at which point it goes out laterally sharply in a hairpin 90-degree turn. This marks the transition point from the M2 to the M3 segment, which will exit at the insular cistern. Finally, the M4 segment represents cortical branches going to the convex surface of the brain. Returning to our axial CTA images, we'll now discuss the posterior circulation. Here we have the right and left V4 intradural segments of the vertebral arteries. As I scroll superiorly, we'll see them start to come together, but before they do, we'll see a right posterior inferior cerebellar artery come off at this point, right here. No posterior inferior cerebellar artery was evident on the left in this particular patient. In about 10 to 20% of cases, the pica, posterior inferior cerebellar artery, is absent or hypoplastic. Usually, when it does come off, it is from this V4 intradural segment, though it is also possible for it to come off the basilar artery or from the V3 extradural segments. Very rarely it can also come from the ascending pharyngeal artery as well. As we continue to scroll superiorly, we can see our basilar artery here, and we'll notice a prominent anterior inferior cerebellar artery on the left, right here. The anterior inferior and posterior inferior cerebellar arteries tend to have a reciprocal relationship, so it is not surprising that this patient that did not have a definitive posterior inferior cerebellar artery has a prominent anterior inferior cerebellar artery. Continuing to scroll superiorly, we'll reach the superior cerebellar arteries, which are here and here. We can see them come into the basilar artery if I go a little higher at this point. And then we'll begin to see the posterior cerebral arteries here on the left and right here on the right. Turning to our axial maximum intensity projection images, we'll now review the segments of the posterior cerebral arteries. First, the P1 segments. These will extend from the basilar tip to the level of the posterior communicating arteries. In about 25% of angiograms, one or both of these will be absent or hypoplastic, and instead there is a large caliber posterior communicating artery allowing blood from the anterior circulation to help supply the posterior brain. Next, we have the P2 segments. These will extend posterolaterally and then posteromedially around the midbrain. The P2A segment is the part that extends posterolaterally in the crural cistern, and the P2B segment is the portion of the P2 segment that extends posteromedially in the ambient cistern. Next, we have the P3 segments, which will extend from the posterolateral surface of the midbrain along the quadrigeminal cistern. Finally, the P4 segments will include the terminal arteries, including the parieto-occipital, calcarine, and splenial arteries. We also have the option to evaluate the intracranial arteries with MRI. Here on this T1 weighted gradient echo time of flight sequence, we have a prominent right posterior communicating artery here, going up to the posterior cerebral artery and separating it into its P1 and P2 segments. As I scroll superiorly, we'll see the P2 segment go around the midbrain in the crural and then ambient cisterns, and further up, we'll see its P3 segment right here, adjacent to the quadrigeminal cistern, and then further back, we'll see the distal P4 branches. I'll scroll back down inferiorly now and point out the internal carotid artery terminus right here. It is from this point that the middle and anterior cerebral arteries arise. Following our M1 sphenoidal segment, we can watch it reach the anterior aspect of the insula, or bifurcation point, where it becomes the M2 segments. These will go up posteriorly and superiorly until they reach the top of the sylvian fissure up here, and then turn out laterally to become the M3 segments, whereupon they exit at the insular cistern to become the M4 cortical segments. Scrolling back down, we'll take a look at the segments of our anterior cerebral artery again. The A1 segment goes right up here, and then arches down slightly to reach the anterior communicating artery seen here. Next, the A2 post-communicating or infracolossal segments will ascend up in the interhemispheric fissure like so. When they reach a point anterior to the genu of the corpus callosum, they become the A3 precolossal segments. When they turn posteriorly, they become the A4 supracolossal segments, and when they get posterior to the coronal suture, they become the A5 postcolossal segments. Let's take a look again at the CTA images we were looking at earlier to review the circle of Willis around the optic chiasm. The circle of Willis consists of a group of arteries anastomosing around the optic chiasm, forming connections between the anterior and posterior circulations. The arteries involved include the internal carotid arteries, the posterior communicating arteries, which we see here on the left and a little further up here on the right, as well as the posterior cerebral arteries, which our posterior communicating arteries are connecting with here on the left and a little further up here on the right. Also, the anterior cerebral arteries are a part of this network. Here at the internal carotid artery bifurcation point into the MCA and the ACA, we're seeing the proximal or A1 segment of our right anterior cerebral artery, and as I go superiorly, we'll see the remainder of it going right up this way. And finally, the anterior communicating artery, which we'll get a better view of if I scroll inferiorly a couple slices, right here, will also be a part of the circle of Willis. We'll now review the circle of Willis on our sagittal CTA images in a patient who is noted to have a couple abnormalities. First, I'll point out the right internal carotid artery terminus right here, and the posterior communicating artery coming off right before the terminus and extending posteriorly. This is a small branch in this particular patient, and as I scroll toward midline, we'll see it connect up to the right posterior cerebral artery right here. Anteriorly, we have the A1 segment of the right anterior cerebral artery as well. Now scrolling further toward midline, we'll see the anterior communicating artery right here, and the A2 branches extending up in the interhemispheric fissure. Scrolling now toward the left side, I'll point out the left internal carotid artery and a small outpouching seen right here. This outpouching has a conical shape, with its base against the internal carotid artery and its apex pointing downward. As I scroll toward midline, we'll notice that the left posterior communicating artery actually arises from its apex and then extends posteriorly to connect to the left posterior cerebral artery. This characteristic shape and characteristic origin of the left posterior communicating artery from its apex is characteristic for a posterior communicating artery infundibulum. This is one of the most common locations to see an infundibulum. If this thing were greater than 3 mm in size, or if the posterior communicating artery instead arose from its base, then it would be suspicious for an aneurysm, and follow-up CTA would be recommended. Infundibula of the posterior communicating arteries are very common, and are seen in about 7% of patients, though some sources say up to 25% of patients will have infundibula of the posterior communicating arteries. Scrolling out laterally from this point, I'll next point out another abnormality as we follow the M1 sphenoidal segment of the left middle cerebral artery. We're going to follow it here along the Sylvian fissure and reach the anterior aspect of the insula, where it will then bifurcate into the M2 branches. Just lateral to this point, we see a saccular outpouching representing an aneurysm. Intracranial aneurysms tend to be saccular or berry-shaped rather than fusiform, as will be more common in the rest of the body. Aneurysms tend to occur in areas of turbulent blood flow, such as those encountered at branch points within the intracranial circulation. This diagram shows the most common locations. The anterior communicating artery is most common and accounts for 35% of cases. Next, the internal carotid arteries, including and especially the posterior communicating artery origins off the internal carotid arteries, will account for another 30% of cases. Next, the middle cerebral arteries, and particularly the M1-M2 junctions, as we saw in our patient we just viewed, will account for another 22% of patients. Posterior circulation aneurysms are less common, but you should always scrutinize the basilar tip, as this will account for another 7% of cases. We're now going to move on to some CTA images to look at some common variants. There are multiple possible anatomic variants for the circle of Willis and other intracranial arteries. For example, in about 18% of cases, you'll see duplication of the anterior communicating artery. In another 5% of cases, there's absence of the anterior communicating artery. In about 2 to 13% of cases, you get trifurcation of the anterior cerebral arteries. This indicates that instead of 2 post-communicating A2 segments, you have 3 post-communicating A2 segments that are going to ascend up here in the interhemispheric fissure. The additional central artery seen in such cases is thought to relate to persistence of the embryonic median artery. If alternatively only one central artery is seen, likely representing the embryonic median artery, and these A2 segments on either side are not developing, you have what's called an azygos anterior cerebral artery. One other variant I'll talk about will be the bihemispheric anterior cerebral artery. Here you'll have one of these A2 segments hypoplastic. This is seen in about 2 to 7% of cases and results in both cerebral hemispheres relying on the dominant A2 segment. Also in azygos anterior cerebral artery, there is a similar dependence on the single vessel ascending for both cerebral hemispheres. This means if it gets occluded, there'll be ischemia and possible infarct bilaterally. We're now viewing a T2 weighted MRI of a patient who was found to have an azygos anterior cerebral artery, seen here. This is a relatively rare anatomic variant, seen in between 0.2 and 4.0% of patients, and it is often associated with neuronal migration abnormalities. As we scroll superiorly here, we'll notice the anterior falx is not developed, and there is greater than 50% fusion of the frontal lobes. We also notice the lateral ventricles are not developed anteriorly, and only a small amount of corpus callosum is present. These are characteristic features for semilobar holoprosencephaly. We've now returned to our coronal maximum intensity projection CTA images, and we'll now use this series to guide a discussion through a few other noteworthy anatomic variants. First, duplicated or accessory middle cerebral arteries. Duplicated or accessory middle cerebral arteries are seen in 2 to 3% of patients. The duplicated middle cerebral artery arises from the internal carotid artery and is larger. The accessory middle cerebral artery will arise from the anterior cerebral artery and will be smaller in caliber. It's possible to get an early bifurcation or trifurcation point of the middle cerebral artery before it reaches the insula. It's also possible to have a persistent carotid basilar connection. This is found when there is a persistent trigeminal artery, seen in 0.2 to 0.6% of cases. It will extend backwards from the distal internal carotid artery and reach the basilar artery right here. The last variant I'll mention will be a common trunk between the superior cerebellar and posterior cerebral arteries. This is a very common variant, seen in about 10% of cases. In all these variants, it is important to look for how aneurysms may develop differently because of different bifurcation points. When a patient has an aneurysm, there's a 30% chance they'll have an aneurysm elsewhere, so always continue looking. This concludes our discussion of cross-sectional neurovascular imaging. Thanks so much for watching, and I hope you enjoyed.